Welcome everyone to today's webinar, and the topic of this webinar will be about the impacts of ligament stiffness on knee joint mechanics in mechanically aligned posterior substituting total knee arthroplasty. My name is Christopher Iversen and I work here at Anybody Technology. And today I'll be the host of this webinar and I'll be assisted by my colleague Bjørn Ingelund during the Q&A session in the end. And in the Anybody webcast series, we host different presenters who have worked with the Anybody modeling system to cover different use cases. And in today's webcast, I would like to introduce our speaker, PhD candidate Junseo Kim from the Department of Mechanical Engineering at Sejong University in Seoul. And Junseo and his colleagues recently published a paper detailing their work on musculoskeletal model with a total knee arthroplasty. And this model was developed using a SWOT model from the Anybody managed model repository, and then designed to evaluate medial femoral rollback, femoral rotation, and joint contact forces. And the paper of this work is already out, so you can go and find all the details in the paper already now. And just before we go ahead and start with the presentation, then I'll give you a general introduction and overview of the Anybody modeling system, if there is any of you that's unfamiliar with the software or musculoskeletal modeling in general. So first of all, I would like to draw your attention to the control panel, which appears on the right side of your screen. And you are very welcome to submit questions and comments via this question panel during the presentation, and then we'll do our best to address these questions at the very end of the webinar. In case we do not get to answer all of your questions, we'll try to do so by email within a reasonable time. So let's begin with having a look at what the Anybody modeling system actually is. Well, the software allows you to do musculoskeletal modeling and simulations, and as input it takes motion data as kinematics and forces, and it calculates the internal body loads as joint reaction forces, muscle activity, and metabolic energy. And at this moment, Anybody is really used in a wide variety of areas and applications. And just to give you a few examples of this, it could be movement analysis, it could be product optimization design, the field of sports optimization, orthopedics and rehabilitation. We have a lot of users in ergonomics with and without assistive devices, as for example an exoskeleton, and we also have a lot of users in the automotive industry. And to give you an idea about the typical workflow in Anybody, then it could look something like this. So you provide the recorded motion data as input, and then you can use the body models which you or others have built. You can then provide some kind of environment, which could be a special type of equipment, or for example an exoskeleton. And then you can use Anybody to combine all of these things and solve the muscle recruitment and run the inverse dynamics simulation. And this basically means that we go from motion to calculating the internal body loads and the interaction with the environment in some cases. We can then output the results and use it for some kind of post-processing, which could be with a kind of finite element tool. But there's also many users who choose to complete this loop by doing some kind of design optimization and then run this cycle multiple times. And this actually brings me to the end of the introduction, so I'll hand over the presenter role to Junseo instead.
Hey everyone, my name is Junseo Kim and I am a PhD candidate in the Musculoskeletal biomechanics laboratory at Sejong University. So first and foremost, I would like to express my sincere gratitude to Anybody Technology for providing the opportunity to present my research today. It is an honor to share my work with this distinguished audience. So today I will be presenting on my work, impact of ligament stiffness adjustment on knee joint mechanics in mechanically aligned posterior stabilized total knee arthroplasty. Thank you for your attention, and I will look forward to engaging with you during this session. So this is very first time to present my work internationally, so please forgive me if there is mistakes or misunderstandings in my presentation. So the presentation will proceed in the order shown on the screen. So first, I would like to begin with the introduction. Osteoarthritis is one of the most common degenerative diseases in knee joint caused by joint aging, obesity, excessive and repetitive joint use, cartilage and tissue damage, trauma, genetic factors, hormonal changes, and joint morphology. Symptoms of osteoarthritis typically include localized joint pain, stiffness, crevices, and sensation of swelling during joint movements. In the early stage of osteoarthritis, non-invasive treatments such as medication and physical therapy are typically applied. If the joint condition continues to progress, minimally invasive procedures such as arthroscopic surgery may be performed first. And osteoarthritis progresses further. Total knee arthroplasty, also known as TKA or TKR, is considered as the final treatment option. And the ultimate goal of TKA is relieving the patient pain and restoring joint function. In TKA procedure, managing tension of MCL, which is medial collateral ligaments, is considered as a critical aspect that directly influences the success of the surgery. Proper MCL tension is essential for achieving optimal knee alignment, ensuring joint stability, and preventing post-operative complications such as mid-flexion instability. So increased tension or unbalanced tension between medial and lateral ligaments can lead to uneven load distribution across the knee joint, contributing to accelerated wear of prosthetic components and compromised functional outcomes. And of course, ongoing research has been conducted on techniques for optimizing the MCL tension balance. Techniques such as medial epicondylar osteotomy and selective needle puncturing have shown promise, but further clinical trials and biomechanical studies require to assess and validate these methods for patient outcomes. In addition, during TKA procedures, selective femoral origin release techniques are employed to intentionally release the MCL in order to achieve optimal soft tissue balance. But there is currently a lack of quantitative guidelines regarding this practice, which means success of optimizing soft tissue balance highly depends on surgeons' techniques and experience. And previous studies, such as cadaveric studies and computational modelings, have predominantly focused on passive flexion scenarios, highlighting the critical influence of MCL tension on femoral rollback and knee joint stability. In computational modeling studies, they demonstrated that external rotation of the femoral components can reduce MCL tension, thereby influencing tibiofemoral contact loads and knee kinematics, emphasizing the role of accurate component positioning. But most of current research has primarily addressed in passive flexion conditions and has not fully explored the complex biomechanical interactions that occur in the dynamic activities. So dynamic activities such as squatting, gaits, and stair climbings can engage the knee joint in substantial femoral rollback, rotational movements, and co-contraction of muscles. And all of these contributes to varying MCL tension. Recent biomechanical investigations have suggested that intraoperative techniques for MCL adjustment should consider these dynamic conditions to ensure balancing ligament tension. However, the limited scopes and methodological limitations of existing studies has left a significant gap in our understanding of how MCL tension affects functional knee biomechanics during these activities. So therefore, the purpose of our study was to investigate impacts of MCL stiffness adjustments on knee joint mechanics in mechanically aligned PS-TKA in dynamic conditions. So next is materials and methods. A musculoskeletal model with TKA was developed based on a squat model from the Antibody Managed Model Repository and Antibody Modeling System version 7.4. The bone geometries of the right femur and tibia were modified by resecting the articular surfaces according to TKA surgical guidelines. And commercially available TKA design made by Corentec in Korea was inserted following mechanical alignment principles. The contact forces for all contact pairs were calculated using a linear force penetration volume law with a contact pressure modulus of 9.3 times 10 to the 9 power. This pressure modulus was calculated using equation from literature down here based on the elastic foundation theory. The squat motion was simulated with a knee flexion driver ranging from 0 degree to 120 degrees using force-dependent kinematics for more accurate analysis of joint kinematics. So force-dependent constraints, were applied to all 6 degrees of freedoms of tibio-femoral joint and 5 degree freedoms of patellofemoral joint, except the medial lateral translation of patellofemoral joint. And the model incorporated 17 ligaments, including MCL and LCL, and the posterior cruciate ligament was excluded to simulate the posterior stabilized TKA procedure. So ligament forces were modeled using nonlinear elastic properties, incorporating slack regions, stiffness, and reference strain, as described in the literature down here, with minor adjustments. And 5 distinct models were developed by modifying the stiffness of MCL, segmented into anterior, central, posterior segments to accurately represent its anatomical configurations. These modifications were designed to simulate various tension states, as illustrated in figure on the right side. So in model B1 and B2, the MCL stiffness were increased by 20% and 40% relative to model A. And in model C1 and C2, the MCL stiffness were decreased by 20% and 40%. And the validation of our musculoskeletal model was based on literatures by comparing predictive values of our model to values from literatures. So next is results of our study. So first of all, the figure shown on the screen illustrates the tension of each MCL segments as a function of knee flexion angle. So tension adjustment of MCL led to an increase in maximum ligament tension to approximately 60 newtons for model B1 and 116 newtons for model B2 at 115 degrees of knee flexion. And conversely, maximum ligament tension in model C1 and C2 were decreased to approximately 62 newtons and 127 newtons at 115 degrees of deflection. So next is the kinematic properties. In case of femoral rollback, there was very minimal variations across models with different MCL stiffness levels. However, relatively distinct differences were observed in internal external rotation and varus valgus rotation, depending on the stiffness. One notable case was model B2, which is black line in these figures. So as shown in this figure, model B2 exhibited sudden movement in lateral rollback during the initial flexion state. Additionally, the model presented a pre-existing internal rotation in the initial posture, followed by a rapid change in internal external rotation during early flexion. Next is tibial femoral joint contact forces. Adjusting MCL stiffness led to a pronounced change in medial contact force, whereas the lateral contact force was relatively unaffected. This was an unexpected effect because we hypothesized that adjustments in MCL stiffness would also have an impact on the lateral contact force. So similar to the kinematic results, model B2 demonstrated an excessive medial contact force already present in the initial posture, as shown in this figure. So lastly, the muscle force characteristics are presented on the screen. So for the biceps femoris activity, very minor intermodal differences were observed during the initial flexion phase. However, for the majority of muscles, the variation in muscle force across models was negligible. So for the last discussion conclusion, so for the discussion, this study provides the quantitative data on the changes in femoral rollback and rotation when MCL stiffness is adjusted, offering practical guidance for surgeons during intraoperative decision making. Adjusting MCL stiffness had measurable effects on femoral rollback, femoral rotation, and joint contact forces, with the changes most pronounced in model B2, which is increased tension for 40% of MCL. So in model B2, significant movements was observed in the initial phase of knee flexion, which is ranged from 0 degree to 2 degrees. So excessive movements in the early phase of knee flexion, as seen in model B2, could result in uneven load distribution across the knee, potentially accelerating wear of the polyethylene insert and leading to premature prosthesis failure. Despite the significant effects of MCL stiffness on knee kinematics, the study showed very minimal changes in muscle activity across the different models. In our opinion, this phenomenon can be explained by equilibrium in the multi-body dynamic analysis, which is in multi-body dynamic simulations, it is essential to achieve equilibrium between internal forces and external forces for the model to converge and produce valid results. So we think that ligament structures, especially the MCL, which absorbed most of the force changes resulting from stiffness adjustments, reducing the need for compensatory muscle activity. So previous research supports this finding, suggesting that in mechanically aligned TKA, passive structures like ligaments play a more prominent role in maintaining stability compared to active muscle forces. So for the conclusion, increasing MCL tension may enhance stability, and it also raises the risk of excessive joint loading and accelerated prosthetic wear. So based on these findings, we suggest that maintaining MCL stiffness within 20% of the normal range is advisable to ensure joint stability while avoiding undue mechanical stress on the implant. So, but there were a few limitations on our study. So first one is the study was conducted using a specific implant type, which may limit the generalizability of findings to other TKA designs. Second one is dynamic motion conditions, such as high-speed activities or pivoting motions or load-bearing movements were not considered in this study, which may have revealed different interactions between ligament stiffness and muscle activity. So last one is the study did not account for variations in patient-specific factors, such as differences in muscle strength or ligament laxity or any other factors which could influence the results. So this is all I prepared. Thank you for your concentration, and you can find our literature in biomechanical engineering letters for detailed informations. And thank you again for listening.
Thank you very much for the presentations. And just before we go to the Q&A session, I would just like to say a few words about our online resources. So if you want to know more about Anybody Technology, then you can go and check out our website, anybodytech.com, where you can find different events, special dates, and also a library of all of our previous webcasts. You can also check out our website, anyscript.org, which is really our community website for people using the Anybody modeling system. And here you can find multiple online resources, such as our wiki page. There are several blog posts and also links to all of our repository sites. It's also here our forum is located. So if you have any questions, then please go and put them there and get some help from some fellow Anybody users. And then I would like to mention a few upcoming webcasts. So we have a couple of webcasts coming up before summer. The next one is already on May 5th, where we host a webcast on the topic of personalized musculoskeletal modeling to predict TKA mechanics from clinical input data. And on June 10th, we also have a webcast about optimizing fracture healing, realistic boundary conditions. And the registration for both of these webcasts are already online. So if you would like to attend or just to sign up to get an email with the recording of the presentation, then please go to our website and register yourself already. And then I would like to mention that we maintain a publication list of all papers using the Anybody modeling system. And this list is available on our website. And recently it reached more than 1,100 publications. So this is really a great place to go and look if you want to have some inspiration on what everyone else is using the Anybody modeling system for. And it's in the same place you'll find our webcast library. And this actually brings me to the end of this one. So I would like to thank you for your attention so far. And then I think we'll take a few questions from the audience.